Good afternoon, everyone. Now, we'd like to start Luncheon Seminar 2, co-sponsored by NOVO Nordisk AS. First, we have a word from Professor Koichiro Kinugawa from Second Department of Internal Medicine, University of Toyama, Japan. Professor Kinugawa, would you give us the opening remarks?
Okay. Good afternoon, everybody. My name is Professor Kinugawa from University of Toyama. I'm now the president of Japanese Heart Failure Society, so I'm going to chair this session. So we invite, this is on, we invited two distinguished speakers. First speaker is Professor Thomas Eschenhagen from Germany. So he's going to talk about cardiac repair with human iPS cardiomyocyte application as engineered tissue. Please.
Thank you very much. And it's nice to be here in this symposium. You will have seen me yesterday, so I'm sorry for some overlap with the things. I'm going to go through the things I showed yesterday quickly. I showed that we are developing this cardiac repair together with Evotec, so that's my conflict of interest. I wanted to start with this slide because we still have some discussion about to which extent the heart regenerates or not. And I think I heard Victor Zhao yesterday talking about progenitor cells. Some years ago, we thought it's time to get together, and you see the people here on the right, you see several ones in the room. I see, for example, Roberto Bolli. Your chair was one of them. The idea was actually to bring different camps together, which, at least that was my feeling at that time, didn't talk to each other before too much. So how is it really? And the conclusion was pretty simple. There is a small cardiomyocyte turnover, which is around 1% per year in the mammalian heart. Bone marrow cells really do not differentiate into myocytes. We concluded that there is, if all, a very, very low number of progenitors and stem cells. And I think the latest study by Bin Zhu really showed there's essentially no stem or progenitor with cardiogenic potential in the mammalian heart. And that means that the positive effects many people see with cell therapy must have another reason, like the paracrine. Okay, but we still think there is means to stimulate cardiac myocyte proliferation or to reprogram the heart, and that's the subject of this symposium, here the right side. And the specific questions here are, since it's possible to make billions of myocytes relatively easy at high quality, the question is, in the focus here, how to bring these cardiomyocytes into the heart. And me personally, I have a long history in cardiac tissue engineering, so I have a bias towards cardiac tissue engineering, and I guess that was a reason for NOVO Nordisk to invite me on the side of the engineered heart tissue. So we started this actually 30 years ago together with Edith Elson, Tetsuo Wakatsuki in St. Louis, but you see Wolfram Zimmermann was a very early member of the team who developed his own program, and as you saw yesterday, quite successfully though. And we did some work here in rats, then with human, in guinea pigs, and since 2 years we work together with Evotec. So I always thought it will be tissue engineering. Why? There are several arguments for that, because the product is quality control. You can easily see in vitro how good the tissues are before implanting them, so that's a clear advantage. And the second thing is, we thought as well that there's maybe higher safety, and third, higher efficacy. Let's see how it is. I showed that picture yesterday. So this is, let's say, just some representative results, what can be achieved with these cells, and A and B is our own work on guinea pigs, and C through F is work on pigs and non-human primates. And you see easily the graphs, and I think what you see here clearly as well, if you put a patch on the heart, there's always, at least in our hands, and I think also from others, there's always the fibrotic scar in between, a fibrotic layer in between the graft and the myocardium, while integration of the cells in cell injection seems better. Okay, so the questions here are, what is the efficacy? How much do you need? What is the mechanism of action? And what about safety? And again, I showed these pictures. People who did this extensively, and I would say systematically on the best possible level in monkeys, and I see, for example, Dr. Shiba here in the room, and Dr. Chong, I mean, many people are participating here. And the conclusion is you can regenerate the macaque heart with injection, with cell injection. However, you need quite a lot of cells, 1 billion per 40 gram, for example. And in average, I would say it's about 10 to 20 million per gram of tissue, which is quite a big dose. We did this with the patches in a guinea pig model, and I showed this again yesterday, and we saw that only the highest dose, which you see here on the right, had an effect, a good improvement of left ventricular ejection fraction after injury. This was a subacute injury model, and we needed 5 million. So that's half to 1/4 of the dose of cell injection. And that for us was always an argument to say it's probably more efficacious to use the patches. How do they work? Is it really the new heart muscle which participates? I showed that concept. We use this optogenetic switch. It works really beautiful. It's a very reproducible, very simple system which you can, where you can in vivo switch on, switch off contractility of the, in this case, injected myocytes. This is here in vitro. And you see here the cell injection leads to a graft. And I showed that picture already yesterday just to show that the grafted cells after cell injection are really intimately associated with the host. Extensive contact zones here, which for me was surprising and nice to see, much more extensive than with what we saw with patches. We were always looking for contact zones. Wolfram did that as well, and it was difficult. While here it was easy to find extensive zones of contact. And the main result is shown here, a small effect we discussed yesterday already. Using the blue light, even though we used a very strong LED light, has a very small penetration depth. So it's possible that the small effect which we see here, which was according to our hypothesis and a proof that indeed contractile force of the graft participates, is in fact bigger. Because we don't really know how deep we come with this lamp, and so it's possible that the true effect is bigger. In any case, it shows that there is something going on. Okay, so that's my summary. The force of the grafted myocardium really contributes. Effect size, I didn't show you here, depends on the graft size. Overall effect is small, but as I found realistic. Indirect paracrine effects probably contribute to the overall improvement. And as I said yesterday already, we were surprised about the efficacy, because here we needed about 7 to 8 millions per gram, so reaching quite good grafts with a relatively low dose. So we sat together with Evotec and said, okay, what do we do? And made a systematic comparison, and maybe that's interesting for our discussion. EHTs on the left, or patches on the left, single cells on the right. I think the big advantage of the patch at this point is that nobody ever showed arrhythmias. That's a safety mechanism. Better cell retention, limited risk of embolism, whatever these cells do in the body, less cells maybe, but the coupling to the host tissue is unclear, and the application, of course, in the end, requires a surgical procedure, which is a downside, from my opinion. On the other hand, cells are much easier to apply. They are applicable by catheter, and that's what Josh is going to talk about. They're easier to manufacture, even though it's not such a big deal to make a EHT patch. But there are also disadvantages, the reflux, or the low cell retention. Maybe that can be solved by the spheroids, where and arrhythmias. And I want to dwell a bit again about the arrhythmias. I talked about coupling. This is our own results showing that in black is a remote myocardium, on the left at 4 Hertz, on the right at 7 Hertz, and you see 1-to-1 coupling in the green, transplanted EHT. At 4 Hertz, at 7 Hertz, it starts to be irregular, So this is actually one of the only evidence that patches indeed can couple. In the case of injected cells, the group of Michael Laflamme, I think, did the most extensive work and showed that the coupling rate was much higher. Some of the, here in green, some of the grafts were also not coupling, but the majority of grafts in the guinea pig were coupling. And I think this is strong evidence that indeed coupling is strong. A second indirect evidence for coupling is that almost all, or actually I think all studies in large animals, in pigs and non-human primates, showed arrhythmias. And the arrhythmias burden was actually quite high. I showed this picture already yesterday. And the group of Chuck Murray really tried to silence these myocytes by knocking out 4 different ion channels, plus overexpressing an IK1-like ion channel. And they could indeed silence the cells and had almost no arrhythmias, but there's here still some in the beginning. We ourselves, yesterday, who did this? Jay asked me, what are we going to do? I'll show you what we are going to do. We are not using an optogenetic approach, but a chemogenetic approach. It's kind of similar, but instead of light, you use a ligand, an artificial ligand. And these are very interesting ion channels, some, so they depolarize if you give this artificial ligand. And there are 2 versions of this, and the blue version here, which is shown here, has a super high sensitivity to varenicline. Varenicline is an approved drug for for smoking, to stop to smoke. And so you see here a nanomolar reaction to this drug. This is in vitro in EHT. So we knocked this channel into EHTs, in iPSC, made EHTs, and applied the drug. And you see it has a very high affinity. And if you do this, look at this time scale here. These are several weeks. You can stop the EHT here in blue by applying varenicline. And then you stop it for 2 weeks. And then, interestingly, contractility comes back to completely normal. And you can do this at different times. So what we think is, this is a very nice, simple strategy to silence myocytes after injection as long as you want. And we are going to proceed with this. So my conclusion is, the injection of iPSC myocytes forms similarly large grafts, maybe at a little higher dose than patch implantation. These cells couple electrically quite robustly, while patches do not consistently. Cell injections bear an arrhythmogenic risk, which requires some intervention, and we have some ideas, as I told you. And in my opinion, immunosuppression is critical on the long term, particularly for mass applications. So I think we have to go towards hypoimmunogenic approaches. It's going to be difficult, but that's what we and several other companies are working on. And with this, I would like to thank you, and particularly these 2 people here, Florian Weinberger as a PI and Tim Studemann, a PhD student. Thank you very much.
Thank you. So thank you for great talks. We're going to discuss later. So
Yes.
We're moving on to next speaker. So second speaker is Professor Joshua Hare. He's going to talk about the cardiac cell-based therapy methods of application and delivery system. Please.
Good afternoon, everybody. It's a great pleasure to be here, and I want to thank the organizers for inviting me, and I want to thank NOVO Nordisk for putting on this lunch symposium. It's been, I think, an incredibly exciting meeting with a tremendous amount of new information and concepts discussed, cell-based therapy, RNA-based therapy, and a variety of different approaches. And that brings us back to a very fundamental issue, which is, regardless of what we will ultimately stand the test of time as an effective therapy, how are we going to get these types of therapies to the patients? We've heard the very elegant work from the previous speaker about surgical application of patches, but I think other catheters are clearly going to be needed. These are my disclosures. As I said, the delivery of cell and gene-based therapies to the myocardium is a necessary challenge to solve for the success of the approach. Delivery can be accomplished easily during surgery, as we've heard, and we certainly have the surgical skills to do this, but the majority of patients do not need surgery. And I think having to expose patients to surgery to get cell-based therapy is going to be a massive burden. So really, catheter delivery systems are needed, and they have been in development since the very early days of this field. So these catheter systems are about 20 to 25 years old, and those of us who've done clinical trials over the years have tremendous experience with them. The regulatory approval of cell and gene products will absolutely need to factor in the delivery methods at the beginning of the development, because the FDA and other regulatory authorities consider the delivery method a key part of the product. So you can't develop a cell product using catheter A and then hope to commercialize it with catheter B. The FDA will send you back to redo your study. So the selection of the delivery method is critical and has to be done early in the development process. I want to spend the next few minutes talking about the catheter systems that are in existence already and those that we have experience with. This development of this field is sufficiently mature that there are already products that have been pulled from the market for failure to success. So we've been able to learn from mistakes already. So the two general types of systems that you should be aware of is those that have a mapping and targeting capability built into them, and the prototype of that is the NOVO system. And then those that are just a delivery system that require you to use traditional imaging, such as ventriculography, which poses a challenge. Over the years, there have been a number of different catheters that have been developed. Basically, these are systems that are catheters that can be inserted into the femoral artery, threaded to the ventricle, and have a needle at the tip that allow you to inject. And basically, there are a variety of different types of needles. I'll show you pictures of all of them. There's a straight needle, curved needle, and a helical needle. Now, the NOGA is the prototype mapping system that has been in wide use, and I would say the most popular. And unfortunately, this system, made by BDS, which is a subsidiary of Johnson & Johnson, has decided to pull this from the market. So right when this field, I think, is experiencing a new resurgence, we're about to lose a system that everybody loves. But fortunately, it will be replaced. The technology is out there already, and it will easily be replaced by other manufacturers. But I'm going to show you the NOGA system so you can understand how it works. The other types of catheters that are worth knowing about is a catheter called the C-cath. I'll show you a picture of it. And this is the most widely available commercial catheter now. And so many of us in the field who are doing studies are turning to the C-cath in this period of time when the NOGA is no longer available. Finally, there's an interesting device called the biocardia catheter, which is a helical needle at its tip. And this has also enjoyed some significant use, not as much as the NOGA. Now, obviously the goal of the catheter is to get the material to the myocardium. And so the delivery system has to factor in a number of key issues, which is this is why mapping is so important. So when you get it and you stick that needle into the heart, what is the outcome? Well, studies have shown that the retention is only 10 to 40%, which is actually pretty good and has been effective in clinical studies. And the remainder of the material is lost by what can be called intravasation. In other words, it's washed out into coronary veins or lymphatics, and then there's some lost to backflow out of the needle track. Now, of course, you have to have skilled operators, because if you fail to engage the needle into the myocardium and you have a missed injection, all of it will be lost in the circulation. So here's some data from Emerson Perrin's laboratory that he kindly shared with me, just showing a variety of studies done in the very early days of this field where the cells were labeled. He used adipose-derived cells in this particular study just to quantify the retention, and then you could see that the retention rate is between 10 and 40%, probably in excess of 25% on average. Okay, so let's talk about the different types of catheter systems. Again, these are long catheters that can be inserted into the femoral artery, have to be passed across the aortic valve in a retrograde fashion, and then have a variety of steering mechanisms so that the operator can direct them to the desired location in the ventricle and deliver with these systems upwards of 10 to 15 types of injections have been used widely in different clinical trials. This is a catheter, an early type of catheter called the myocath. It's got a straight needle at the tip, and the operator can manipulate it by being able to introduce this curve at the end, and so therefore can manipulate its location in the ventricle. The MyoStar is a similar type of catheter. This is the catheter that is part of the NOGA system, so it has NOGA mapping capability. The needle can be extended, and you can control the length of the needle, which is very important because you don't want to perforate the ventricle. So by knowing how thick the ventricle is, you can dial in to the catheter system how far the needle should protrude, and basically we tend to keep that needle length less than 50% of the myocardial thickness. Now this is the C-Cathers injection catheter. As I said, this is commercially available. It has been used widely in a variety of clinical trials, and this is a very nice system. It was designed with the intent of maximizing retention, and by having this curved needle path with side holes, the expectation is that there can be a much greater retention, and the curved path eliminates the efflux back into the ventricle. We're doing a large clinical trial right now called the Poseidon DCM2, and it's a 136-patient study. And unfortunately, halfway through enrollment, we're not even quite halfway through enrollment, the Johnson & Johnson catheter is being withdrawn, and we will have to switch to and plan to use the C-cath for the remainder of the study. Many other ongoing clinical trials are in exactly the same position. So fortunately, this catheter is available on the market. The BioCardia Helix is a unique system that has a curved needle at the tip. It's based on the type of needle that's used on pacemaker screw-in leads. This is a nice system. It's been available for about 20, 25 years. We've used it widely in our group, but unfortunately the manufacturer of this catheter doesn't make it available to whoever wants it. They're very selective in who they allow to use the system, and so therefore many trials have been done without the ability to use this catheter. Now here's an example of a catheter that has been pulled from the market, and I think very true to its name. I think naming it the Stiletto might have portended that it would need to be withdrawn, because this catheter had such a powerful spring-loaded needle that the perforation rate was unacceptably high, and the manufacturer had to pull this. So as I said, we have learned from mistakes about what not to do, and the gentle introduction of the needle is important. There are other types of approaches. This is a very interesting system called the trans-axis delivery system catheter that allows you to thread this retrograde into the coronary sinus, which is part of the venous system of the heart, and inject into the ventricle with guidance, IVUS guidance. So it has an ultrasound capability at its tip. Okay, so let's talk about conventional imaging and how conventional imaging is critical in the field to target where you're going to go and to map in subsequent imaging studies the reaction to that local injection of cells. So obviously from the very early days it became important to try to do this overlay, to try to keep track of where you've injected product and then follow that area up. This is a very early study from my colleague Dara Kreitzman at Johns Hopkins, who was in the radiology department there, and she did some very elegant work about overlaying different imaging techniques, SPECT-CT, MRI, and nuclear medicine techniques, and she could show this in a canine model that she could map where the infarct is using the MRI, and then deliver the cells specifically to that area, and then follow that. So those concepts have about a 20-year history. MR imaging has become, I would say, standard, and I would recommend MR imaging to every investigator who's going to do a study with myocardial infarction, because of its ability to look at the myocardial properties, delineate infarcted tissue from non-infarcted tissue, and to also look at functional, global and regional function, and I'll talk more about that. I just want to talk a little bit more about mapping before we go back to MRI, and I think that mapping is the future, and it's unfortunate that the NOVO system has been withdrawn, but it will be replaced by other systems. There's a very elegant system I saw recently manufactured by Abbott. That's extremely nice. So these mapping systems have been introduced not necessarily for this field of cell delivery, but mapping is very, very important for electrophysiologists. And procedures like VT mapping and atrial fibrillation ablations require the use of these systems. They can then be reconfigured to do electroanatomic mapping, which can be used for cell therapy. So they have the capability of measuring function and electricity at the tip, and so therefore you can determine whether a segment of myocardium is contractile and whether it has an electrical activity, thus electroanatomic mapping. The system comes on a device, and you can see this is a photograph of our cath lab from a few years ago, where you can integrate all of the imaging, your technology you're using right in the cath lab, so the operator can have the maximum amount of information to decide where to deliver. So as I said, it's electroanatomic mapping. You get a color map, and then that can be correlated and overlaid with MRI. So you can see, for example, the area that has the infarction is red, and that corresponds in a anatomic distribution to what you see on the delayed hyperenhancement MRI. So this is more work from Emerson Perrin. He's really a pioneer in the use of the NOVO system, and he shows in this study how he could look at regionally, and by looking at the magnitude of the unipolar voltage, estimate the thickness of the scar, for instance. So this, I think, sums up how useful electroanatomic mapping is with injection capability. You could see an infarct scar right there, the red area, and the catheter localization system is so precise that you can actually fill in a number of injections right around the border zone of the scar, which is, and has been up until now, the chosen location to deliver the types of cell-based therapy that have been used in clinical trials up until now. Now that may change, of course, as we think about remuscularization strategies. We may want to deliver right into the infarct scar, and of course, these are the types of nuts and bolts translational studies that will have to be done prior to the field reaching its goal of successful remuscularization. Just a few more slides from our work that can show you how you can also deliver to the chosen location without having mapping. So it is possible to do it without mapping. It's a little bit more cumbersome, but here's a study that we did many, many years ago. We started this work in about 2005, so almost 20 years ago, with the BioCardia system, just using ventriculography as the guide by looking at the akinetic segment. And you can see what we did. We did a ventriculogram in the middle. We outlined the left ventricular border in the RAO and LAO view, and we could map where our injections were and then overlay that onto a 17-segment polar map. And by doing that and having a pre-existing MRI, it gave a tremendous amount of power to us. Professor Pettigrew this morning showed also his work with MRI and how using circumferential and radial strain can be a very powerful technique to look at regional function. And we, in fact, did that. We could map the location of the scar, the regional function, inject into the desired area, and then map the regional function later as a consequence. And here's a nice example from our very first paper in humans using mesenchymal stem cell injections. You can see in the color-coded that the abnormal eccentric strain is colored in red, and green is normal. It corresponds to the infarct zone, which is shown in the polar map below, obtained from the MRI, and you can see that over 1 year, the red area converts to green, so that regional area is starting to contract, and that corresponds with a decline in the scar burden. So these types of approaches can be very useful, and you could either think about doing this type of approach or the electroanatomic mapping. So in terms of regulatory considerations, I just wanted to throw this slide in there because I think it's very important as new approaches are being tried, again, just to reinforce that you must think about your delivery system at the beginning of your trial if you're going to use a catheter system, because you do need to show that there's compatibility of the therapeutic product with the catheter delivery system and to identify the dose limitations, because the FDA and other regulatory agencies will make you show that that the cell product is viable in the concentration that you're using after passage through the needle. In addition, it's also good to know ahead of time what the need for preclinical studies will be in appropriate large animal models by the regulatory agency. So just to summarize, there is extensive experience with delivery systems and cell-based therapy trials over the last 20 years. There's a very strong safety record, as evidenced by the fact that these same systems, except for the stiletto, have been used in multiple trials. It is an effective way to deliver. It can be done in multiple injections in desired locations in the ventricle. In terms of targeting, the two broad ideas are to use electroanatomic mapping, which is inherent into the system, or use an imaging overlay approach where you combine multiple imaging systems. And then, of course, dosing and distribution capability are important considerations. Thank you for the opportunity to talk at this symposium, and I want to credit my lab, a terrific team, and very significant funding from the NHLBI that goes all the way back to 2005 when we got a Specialized Center for Cell-Based Therapy award, which allowed us to begin this work in animal models and take it into clinical trials using the delivery systems I've talked about here. So thank you again.
Thank you for an excellent talk. So we have 10 minutes left for a discussion. So Professor Eschenhagen nicely summarized the pro and con of the EHT and injection systems, and also Professor here introduced multiple catheter delivery systems, and also the benefit of the location using MRI. So is there any questions from our audience and comment?
Hi, this is for Josh. I enjoyed your presentation as always. I just want to throw a somewhat provocative comment. It's not really a question, it's a comment. looking at your data, so only about 25% of cells are retained in the myocardium with transendocardial injection, 10 to 40, let's say 25%. And by the way, that's only short term, right? Because we don't know, like 1 week later, but let's say 25%. And the rest are going to the systemic circulation either through the venous system or the Thebesian veins or even reflux into ventricular cavity or whatever. So we've always thought our goal is to maximize retention, but I am proposing a different view that maybe that 75% of cells that do not that are not retained and go into the systemic circulation are also beneficial because they may exert systemic immunomodulatory and anti-inflammatory actions which help patients with chronic heart failure, where, as you know, there is a chronic inflammatory state. So the intramyocardial injection may be viewed as a hybrid between a local delivery causing local effects and a systemic delivery causing systemic effects. And maybe the systemic effects are also necessary for the beneficial or therapeutic actions that we are seeing with cell therapy. I don't know if you have any thoughts. I'll show some data tomorrow with intravenous. I'm just setting the groundwork for tomorrow's talk with intravenous delivery of cells, which I'll show you some data. But certainly, one could think about both actions, right? A local action and a systemic action of cells.
Yeah, thanks, Roberta. I agree with you completely that as the field has shifted in its thinking from very early on, that it's that there are paracrine effects, and we're starting to see the data come out from even the pluripotent stem cells studies having paracrine effects. So I think paracrine effects are an essential part of the therapeutic benefit of these types of products. So you're exactly right. It may be that there's a systemic effect in terms of immunomodulation or vascular repair or a variety of other things. And you're about to start a very, very exciting trial that it will look at intravenous delivery. And there's already some data on intravenous delivery as a way to have systemic effects. And
I have a question for one question for each of the speakers, actually. Perhaps I can start with Professor Hare. In your experience, can you just tell how, what volumes and number of cells are you able to deliver through the CCath approach, for example, and how long does that take? Because we're thinking of delivering at least maybe a billion cardiomyocytes, for example. So how long would that procedure take?
Yeah, so it's actually a very straightforward procedure, and a skilled operator can do, I would say, 10 to 15 ejections in 30 to 40 minutes max. So it's the same duration of a therapy that, for example, if you were having an angioplasty, it's less complicated and less time than an aortic TAVR, for example. So I think it's a very acceptable amount of time, under an hour for the whole procedure. Now, the issue you raise of dosing is critical, and it's really concentration, right? Not so much the amount, because there are limits to the concentration that you could pass through that needle. I think that 1 billion would be challenging because most studies up until now using mesenchymal stem cells and other related products have used dosing that is maxed out at 200 or 250 million cells. I think that to go to 1 billion would be challenging because of the need for an increased number of injections, and the injections do have some morbidity associated with them, because every time you stick that needle into the myocardium, you are going to damage some myocytes. So that's what I alluded to very generally in my comments about needing to work things out translationally. Now we actually have done a study with embryonic stem cells, embryonic stem cell derived myocytes in pigs, and we were able to deliver up to 1 billion cells in about 15 to 20 injections. But we're still analyzing the data to see how well that worked.
Sorry, did you have a comment on this?
No, I actually have a question, but go ahead.
So I had a question for you actually, which was vascularization. To what extent did you see vascularization into the engineered heart tissues? And did you attempt to sort of manipulate that and augment that vascularization?
Yeah. You do see very fast ingrowth of host vessels into the engineered heart tissue. And I think the group of Dr. Shimizu studied that systematically, Matsuo Aora, and it took about 3 days, or two to 3 days, until the first vessels are really in. And so there is this first period of more or less complete hypoxia. As Wolfram yesterday said, these cells are hypoxia resistant, quite surprisingly hypoxia resistant. But we looked after 1 week, and you saw vascularization, but you also saw a lot of disassembly of sarcomeres, so the cells look really degenerated, and then they come with the ingrowth of the blood vessels, they recover, form more sarcomeres, grow, and get better. I think nobody ever really systematically and statistically validly looked how many cells died in this first period. But I'm sure there is also initial cell death in the patch approach, and then there's also proliferation, so there's a mix of both going on, and in the end, you have certainly less cells than you inject, than you patch, but not the order of magnitude. It's kind of, I think we calculate around 50% after 4 weeks of what you patch on.
Great, thank you.
Well, actually, what I wanted to ask you, I don't know whether, I think one of the questions I always ask myself, these catheters, which are really quite impressive, I think, and I fully agree, it's really a mature technology, have mainly been tested with smaller cells, like bone marrow-derived cells, mesenchymal cells. These cardiomyocytes are relatively big, and I was wondering whether anybody systematically checked for viability of these cells, because I mean, everybody who works in the lab knows that these cells don't like shear stress. So we handle them carefully. We try to not pipette them with very thin pipette tips. So I was wondering what happens if you move these cells through this long catheter, and then this, is it known? Did anybody did that experiment?
Yeah, we did that. So as I mentioned, the FDA requires you to do that as part of any IND, and we were able to obtain the cells that Chuck Murray used in his study from City of Hope as part of the NIH PACT program. And we did test, and the cells do remain viable
like
through
80%, 100%, 60%.
The
is there a number?
Yes, I don't have the exact number, but the viability after passage that's considered acceptable is, I can send you the exact numbers, but it's usually in the 80 to 90% range. I think anything below 75 or anything below 80 would be of concern, would be suggesting that
the entire passage through the catheter and the tip.
Yes.
That's important.
Yeah.
Okay, so final question.
So, Professor Hare, you have a lot of experience to transplant cells into the heart. So, and you showed several important points to make the catheter. So, what is the most important point and the necessary point to make the new catheter?
I would continue to favor using electroanatomical mapping, especially for ischemic cardiomyopathy, which is the #1 disease that we're going to be treating with cells. There's certainly also a big need in the dilated cardiomyopathy, but I think mapping is much less important in dilated cardiomyopathy, and it's possible that you may be even able to treat non-ischemic dilated cardiomyopathy with intravenous therapies, as we discussed with Dr. Bowley. So I think the EAM systems are very important, and therefore the catheter needs to be compatible with the electroanatomic mapping system. And then, of course, the other critical thing is that it needs to be safe. So I think what we'll see is in the next 2 or 3 years, if we have this discussion again, we'll have completely new systems that will have been developed that are EAM compatible and safe.
And what is most reliable or useful catheter among current condition?
The three I showed are very safe and reliable. The Johnson & Johnson catheter, which unfortunately is now being withdrawn, so it's no longer available. And then the two others that have the most wide use is the C-cath, the curved needle, and the BioCardia, the helical needle.
And in the future, when we want to transplant the regenerated cardiomyocyte directly into the scar area, do you have any ideas to regenerate the scar tissue?
I'm sorry, can you repeat the question?
Right now, it is very difficult to transplant the cardiomyocyte into the scar tissue because probably the transplanted cardiomyocyte will be isolated by a scar tissue.
Yes.
But in the future, can we solve this problem according to your idea?
Absolutely, and I would say that I think your product is one of the most promising, very exciting, and congratulations on getting into humans in the surgical study that you're doing now. And I think absolutely it would be very exciting to see some data with your product injected into animal models.
Thank you very much.
Yeah. But I mean, sorry, I think you were alluding to the scar issue.
Sorry,
and I don't know whether anybody here, I'm not aware of any study which showed the scar disappearing. What I see is that there's addition of new myocardium to the scar, but that the existing scar is disappearing, I'm not aware of any study.
There's plenty of data that scar size can be reduced with mesenchymal stem cells. I also believe that I believe that Chuck has shown in his studies. It's either Chuck or Laflamme has shown using MRI reductions in the scar burden with MRI.
But isn't that a relative value because the rest is getting bigger?
No, there are absolute reductions.
Here we are.
Yeah, there are absolute reductions in scar, and the presumed mechanism is release of matrix metalloproteases that are capable of digesting collagen fibrils. So there's quite a lot of data, in my view, that scar size can be reduced by a variety of products.
Okay.
Just a quick comment. We've injected cardiomyocytes directly into scar. We do see that the scar decreases, but it's a little bit haphazard which cells are surviving. That's a bit of the problem.
Right.
So we target the border zones, and within scar we have seen cardiomyocytes surviving within scar out to 28 days post. But at the moment, it's a little haphazard. Our understanding of which cells survive, which regions, is unclear.
What types of cells have you?
iPSC-derived cardiomyocytes.
Cardiomyocytes, yeah.
This is when I was doing in Chuck's lab and then in our own lab in Sydney too.
We've reproduced that work in our lab, and you can get the myocytes to survive with immunosuppression. The minute you stop immunosuppression, they all die.
I mean, that's actually another issue. But
yeah, and I think these types of cells, as many people are showing, have the ability to be engrafted and potentially increase contractility, as you've shown. But they also very clearly have a paracrine effect. And do a host of other cardioreparative things. So I think that the paracrine hypothesis is probably a universal feature of these types of cells that are going to be cardioreparative.
Okay. Okay, so thanks for a great discussion. So it's time to close this session. So I hope everybody enjoys the rest of the symposium. Thank you so much.
Thank you so much, Professor Koichiro Kinugawa, Professor Ishimo Hagen, and Professor Hare. The Luncheon Seminar 2 is now closed. Please hand an empty box to the staff at the exit on your way out. Thank you very much for your participation.